Let's talk about JAK inhibitors for inflammatory bowel disease. These are highly effective drugs for ulcerative colitis and now also for Crohn's disease. They have a very rapid onset of action. We may be able to use them without steroids. And in fact, they look like they work quite well when TNF drugs have failed, something that we have not seen to date with newer generation biologics. In this video, we're going to look at the discovery and biology of JAKs. We're going to look at the three drugs in ulcerative colitis: Tofacitinib, filgotinib, and upadacitinib. We're going to look at Crohn's disease. Why did Tofacitinib fail? What's the great new data for upadacitinib? Where is filgotinib? Where is the data coming for that? We're going to look at the safety. We're going to look at the PRAC 20 that's just been released by the European Medicines Agency. We'll have a little bit about positioning of these drugs in both ulcerative colitis and in Crohn's disease, and we'll look a bit to the future, perhaps using these drugs at a later date in acute severe colitis. What are the new molecules coming, and perhaps targeted delivery as a way of getting higher levels of the drug with lower toxicity. Let's start at the beginning. The JAKs were discovered by Wilks in 1989. They are a family of intracellular tyrosine kinases. After Wilks' discovery, early on there was a partnership that developed between Pfizer and the NIH. That led to the discovery of Tofacitinib, which was first tested as a proof of concept back in 2006. The JAKs work inside the cells to transmit the signal from a cytokine. So here you are. Let's zoom in to this just now. You have a cytokine receptor. On the inside, you have a JAK, but you have two of each. So when the cytokine, say an interleukin, might be interleukin 12, binds to its pair of receptors, you have these JAKs. Importantly, as the next step, you get an ATP molecule that binds to the JAK. That then phosphorylates the intracellular portion of the cytokine receptor. You then have STAT molecules that come in, they dimerize. The JAK helps to put an extra phosphate on the STAT. This STAT complex is then able to translocate through to the nucleus and upregulate transcription of multiple new proteins. This is how we get the signal from a cytokine through to the nucleus to transmit its message. The JAK family consists of four members: JAK1, JAK2, JAK3, and TYK2. And these ultimately transmit the cytokine signals that you can see on the screen, and they all then signal through 6 STAT proteins. There are many different cytokines that signal through JAKs. The important and notable exception to this is TNF, and that is probably why these drugs work well when TNF has failed. It is very interesting to note that there are multiple gene association hits with IBD susceptibility within the JAK-STAT pathway. That includes JAK2, that includes TYK2, that includes STAT3. It also includes multiple cytokines. Of course, the IL-23 receptor is there, oncostatin M receptor. This suggests the high importance of this pathway in IBD and suggests it might be a very good pathway to target with drugs. So following on from the Tofacitinib development, it was first approved in rheumatoid arthritis in 2012, in ulcerative colitis in 2018, and then you can see following on from this the development of filgotinib and upadacitinib, not just in ulcerative colitis, also Crohn's disease, and for many other immune-mediated diseases affecting the skin and the joints. Interestingly, if you look at Tofacitinib, now over 500,000 people have been dosed with the drug across all indications. For upadacitinib, if you look, I think there are now 18 phase 3 randomized controlled trials across joints, skin, and bowel. These different JAK inhibitors have different potency towards the individual JAK isozymes, contributing to different selectivity profiles. So you have Tofacitinib, which is covering JAK1, JAK2, and JAK3, all a bit more than TYK2, so it's a proper pan-JAK inhibitor. and upadacitinib and filgotinib, which are much more selective for JAK1, but both with slightly differing profiles. Now, selecting a JAK1 inhibitor is quite difficult, or making a JAK1 inhibitor is quite difficult, because these molecules bind or work by acting and blocking the ATP from binding to the JAK molecule. So they sit in the ATP binding pocket. Now, this ATP binding pocket is highly conserved across the JAK molecules. In fact, it's 85% conserved if you look across JAK1, JAK2, JAK3, and TYK2. And so developing a JAK1 specific molecule is very, very difficult to do. It means that at higher doses of these drugs, all of the drugs have some pan-JAK inhibition, and you can look by doing enzymatic assays, measuring the ability to block ATP binding site of specific JAK isoforms in vitro or in silico, and you'll see on the screen this table with the different numbers there demonstrating that all of these molecules have different abilities to block the different JAK isoforms, and this means that they are all slightly different, and I think also means that these are not interchangeable molecules, which is an important, perhaps, first lesson. The other thing to note is that if you accept that none of them are going to be truly JAK1 selective, and that particularly at higher doses that's going to be the case, even if you're blocking JAK1 specifically, you're blocking a multitude of different cytokines, as you can see on the screen here, because you have JAK1 in pairs with JAK2 for IL-2, IL-4, for example. You have JAK1 with TYK2 for IL-10, IL-22, interferon alpha and beta. You have JAK1 with JAK2 and TYK2 from static M and IL-6, for example, as you can see on the screen. Finally, the impact of selectivity depends on the concentration of JAK inhibitors in the tissues, which is influenced by many things, as you can see on the screen. So let's look at the data. Let's first look at ulcerative colitis, where we've got most of the data and where we have 3 drugs available to us. Here we have the data for Tofacitinib with the Octave studies, we've got filgotinib with the selection studies, and we've got upadacitinib with the UAchieve and the UAccomplish studies. And what I'm showing you here is the induction data, week 8 or week 10 in the case of filgotinib. All of these drugs meeting primary endpoints for induction in their key registration studies. These drugs work quickly, and we see that for all of the drugs. This is the data for Tofacitinib, where we saw that first. You can see in a number of days a significant reduction from baseline stool frequency versus placebo on the left, and in the right, a significant reduction in terms of the rectal bleeding score. This is indeed our experience in the clinic. In Edinburgh, we've treated about 250 patients with Tofacitinib for ulcerative colitis, and in a significant number of patients, we see this very rapid onset of action. Filgotinib has shown similar data in its clinical trials program, as has upadacitinib. This is looking from week 2 to 4 to 6. You can see the clear separation here for UAchieve and UAccomplish. If you then look in the days score again, you can see significant separation for the stool frequency score and rectal bleeding score. Already at day 1, we see a similarly impressive separation for rectal urgency. And then if you look out to week 2 and week 8, you see improvements already that are significant for fatigue in both UAccomplish and UAchieve. And then if you look out to the maintenance data, again, all 3 studies, the same layout. This shows steroid-free clinical remission at a year. These are all randomized responder studies, all demonstrating significance against placebo. You see here for the 2 Tofacitinib doses, a delta of about 10%. There's just the 1 dose of filgotinib, 200 milligrams, remember. And then on the right for upadacitinib, again, you see a delta of about 10% for this steroid-free clinical remission in the randomized responders design. I mentioned earlier that these drugs work where TNF has failed. This is the data for Tofacitinib, and you can see here all patients on the left. In the middle, you see the non-TNF failure patients, and on the right, the TNF failure patients. There's a very robust delta for drug versus placebo, even when TNF has failed, although noting that some of these patients will likely need the higher maintenance dose of the drug, and indeed that's what we see in the clinic. So that's very briefly on ulcerative colitis and the data. There's a wealth of data here that I'll come back to at a later point in more detail. What about Crohn's disease? Tofacitinib failed its phase 2 to 3 clinical trials program. It's interesting to think why. This drug, I think, probably does work for Crohn's disease. We've used it in a number of patients with some success. The phase 2 study was very flat, but did start to show some benefit up at 15 milligrams twice a day when you looked at the biomarkers. In the phase 2b studies, the RCTs here, there was no statistical benefit seen, and so the program was dropped. There is one real-world consortium, the TROPIC Consortium. It's about 79 patients here from North America demonstrating real-world effectiveness in Crohn's disease, and that mirrors our experience in Edinburgh. The drug that's got evidence for efficacy now is upadacitinib. This is new data from the UEXCEED induction and the UEXCEL induction program. This is quite similar to what we've seen before, where you've got 2 placebo-controlled induction studies, then randomized responders into the maintenance study. Here you've got 45 milligram drug versus placebo for a 12-week induction. You can see the primary endpoint at week 12 here, with a reduction in CDAI on the left, the stool frequency and abdominal pain score in the middle, and endoscopic response on the right. All meeting primary endpoints, very robust induction data for UEXCEED. Here are the data for UEXCEL, all showing significant endpoints there. Randomized responders then go into the maintenance study. Here, patients are randomized to either the 30 milligram or the 15 milligram dose. You can now see the primary endpoint. This is co-primary endpoints, clinical remission at week 52 plus endoscopic response. You can see this is met. You can see it's met for both doses of the drug, but with about a 10% delta between 30 milligrams and 15 milligrams across all these different endpoints. So this is very encouraging. This shows us that we have a new drug to work in Crohn's disease. We don't yet know if filgotinib will also show efficacy in Crohn's disease. The drug met its primary endpoint in the Fitzroy phase 2 study. It's now gone on into the Diversity phase 3 program. This study has finished and will have its readout in, I think, the first half of next year. So we'll look forward to seeing those data for filgotinib in Crohn's disease then. Interestingly, this year we had a phase 2 study of filgotinib in fistulizing Crohn's disease, suggesting the drug may work there. And I think this gives us a really interesting clue that this class of drugs may provide some really great new option for patients with fistulizing disease. Obviously, a really difficult phenotype, particularly when TNF has failed. Let's move to safety. I'm going to focus here in on the Tofacitinib data because this is where we have the most data points. We can see from 8 years of the clinical trial program. This is from Octave, the open label extension, and the riveting study. Here you can see the incident rates for serious infections, malignancies, for major adverse cardiac events, and thromboembolic disease. You can see overall these are all less than 2 and don't appear to be giving us any real cause for concern. It is worth noting that a lot of this is age dependent. That includes the definite increased risk of herpes zoster, which appears to be a class effect, up to about 5.6 cases per 100 years. If you look at this overall, we see this now, so I think this is an important thing. We can vaccinate against it. We can talk about that some more later. But if you vaccinate with The old vaccine, Zostavax, you have to do it when patients are off immunosuppressant. That includes prednisolone doses less than 20. There needs to be about a 4-week window before you start a JAK inhibitor. That's not great, particularly when you want to use a drug that works fast, obviates steroids. But Shingrix is a recombinant vaccine. You can use it with the immune suppression. You can give the 2 doses as close as 4 weeks as apart. Access issues have been difficult because of supply, but I think there is enough of the drug now, and I would encourage people to look at the mechanism to get patients vaccinated at the start, if not at diagnosis for high-risk patients with inflammatory bowel disease. A lot of the safety data around Tofacitinib came from rheumatoid arthritis. That led the FDA to mandate a phase 4 study called Oral Surveillance. This is a study that compares anti-TNF with JAK inhibitors with Tofacitinib in patients with rheumatoid arthritis who are over the age of 50 and have at least one risk factor for cardiovascular disease. Patients were randomized to either Tofacitinib, 5 milligrams twice daily plus methotrexate, or adalimumab or etanercept plus methotrexate. They were followed for a period of time until enough endpoints were accrued, and the endpoints of interest were major adverse cardiac event and malignancy. There was a pre-specified cutoff for non-inferiority with a hazard ratio, upper limit of which was 1.8 based on previous data. In this study, that hazard ratio was breached. For major adverse cardiac events, the hazard ratio for Tofacitinib versus anti-TNF was 1.33, with a range from 0.91 to 1.94. And for adjudicated malignancies, the hazard ratio was 1.48, with the upper limit of 2.09. That meant that you could not say that Tofacitinib was non-inferior to anti-TNF when combined with methotrexate in this rheumatoid arthritis population enriched for cardiovascular events. When you look at this in more detail, you see it's the patients with a history of coronary artery disease and who are at high risk of cardiovascular disease who are enriched for these events. And for those patients that smoked in the study, it was patients with a significant PRAC year history of smoking who were at higher risk. Nonetheless, this led to a label change across all JAKs by the FDA, and then to this PRAC 20 investigation by the European Medicines Agency for all IMiDs that has just reported. This has recommended that to minimize the risk of serious side effects from JAK inhibitors used to treat multiple immune-mediated diseases, that these medicines should only be used in the following patients where no other treatment options are available. So that's older patients, and here it's over 65, those who have an increased risk of major adverse cardiac event, those who smoke or have a significant prior smoking history, and using caution where those have other risk factors for deep venous thrombosis or pulmonary thromboembolic disease. So what does that mean? Well, it means that the risk, apparently, according to the EMA, is identical across all JAKs, and this is for all immune-mediated diseases. It means that we can use the drugs. It means that we can use the drugs in all patients, but in the patients that don't have these risks, we can use them first line. In those that do, we need to use them when other drugs have failed. And that seems to me to be a very reasonable approach. The ECHO standpoint, written before this was published, is very similar. It says, when extrapolating from findings from all surveillance, it is important to consider both differences in epidemiology and risk factors in Crohn's disease, ulcerative colitis, and rheumatoid arthritis. You see the pathogenesis is different. You see the phenotypes and demographics are different. Patients with rheumatoid arthritis tend to be older, more likely to be obese, more likely to smoke, more likely to have type 2 diabetes and hypertension. Important to note, all 3 JAK inhibitors differ in terms of their selectivity, dose, cytokine inhibition, efficacy, and safety profile. Treatment decisions should be determined by patient profile and the benefit-risk profile. And the positioning of the JAKs, according to the ECHO standpoint, should be kept before or after biologics. And I think that is true. So what is the positioning? Well, this shows you what we've done in terms of positioning of advanced therapies for ulcerative colitis in Edinburgh. You can see prior to 2015, very little advanced therapy used apart from rescue therapy for acute severe colitis. You then see infliximab, a bit of adalimumab, quite a lot of vedolizumab first line. You then move later and you can see tofacitinib coming in first line and a little bit of ustekinumab. If you look second line, you see a lot of vedolizumab, some infliximab, some adalimumab, and quite a lot of tofacitinib later as well. And so I think for these drugs, we will see them sit within a treatment pathway, both first line for patients who are not meeting those high-risk criteria by the PRAC 20, so certainly adults under 50 or 60 without risk factors. I think these offer an excellent first-line choice. And in other patients, we can use them later on when the drugs have failed. Important to note that we don't have head-to-head studies to truly determine where these drugs sit in ulcerative colitis. We may never get that, although it'd be very nice to have so. We do have some indirect comparisons. We have the network meta-analyses that have been published, I think 3 now in the last year. This is just one of them that demonstrated the JAK inhibitors coming out very well in this. Here, upadacitinib came out top in terms of both clinical efficacy and endoscopic endpoints. There's a lot of information in these studies that you can drill down into. What about Crohn's disease? Well, the honest answer is we don't know yet. TNF is hard to push away from first line in Crohn's disease because it's so effective and so cost effective as well. The fact that these drugs look to work well when TNF has failed may place them as the first drug after TNF failure, and perhaps for some patients first line as well, but we'll need to see what happens in the future there. A few words about future directions, and to start with, I want to think about acute severe colitis. The first thing I want to say is that I don't think should be using JAK inhibitors in acute severe colitis yet, save for in very specialized centers, in very, very closely monitored situations, because we just don't have enough information yet. However, we do have some. The data that Peter Higgins has generated in North America stems from the observation that higher doses of tofacitinib, that was 15 milligrams twice daily in the phase 2 study, was highly effective, although limited by safety. They've then done this initial study with 40 biologic-experienced acute severe colitis patients, dosed with tofacitinib 10 milligrams TDS for 3 days, demonstrating that with this dose, there was a significant reduction in colectomy rates, only 8% in this cohort. And that was compared to both standard dose tofacitinib and normal therapy. Worth noting, it's only for 3 days, this high dose, in the initial dose. So this is something to watch. Other drugs, well, TYK2 looks like a very interesting target. Unfortunately, deucravacitinib, the first molecule to come through phase 2 testing, failed in ulcerative colitis. There's another TYK2 molecule, VTX958, being developed by Ventyx Biosciences that Bill Sanborn is now President and Chief Medical Officer for. This study reported very promising phase 1 studies in a large group of healthy individuals this summer and is now moving forwards to phase 2 testing. There are other molecules coming, in particular as the ritlecitinib and brepocitinib, 2 Pfizer molecules that reported some encouraging phase 2 data at UEG this year, and we'll look forward to seeing them coming through development in the coming years. Finally, is there anything else that we can do? I've talked a lot about safety here, and I think the observation ultimately that the dose of the drug will be limited by safety. But if we could get higher doses of the drug to the tissue directly, to the colon, then that might improve things further. Bram Verstock at Leuven showed very neatly that you have correlation between tissue and serum exposure, but also that it's the tissue level that predicts response to tofacitinib. And there are a couple of companies now developing targeted tofacitinib to the gut to get higher concentrations there with lower systemic levels And that's a very interesting thing, I think, to look out for in the future. So I think we made it to the end. If you've made it this far, thank you for watching. Just to summarize, these drugs are, I think, highly effective for ulcerative colitis. We've shown that. They work very fast. They work without the need for steroids. They're working when TNF has failed. They're meeting their clinical induction endpoints. They're meeting their maintenance endpoints. They're meeting their mucosal healing endpoints. And we've got 3 drugs here: Tofacitinib, filgotinib, and upadacitinib. These drugs also work in Crohn's disease. The data we have so far is with upadacitinib. This looks highly effective molecule here, and we look forward to that next year. So they're already available, rapid onset of action. That really is game-changing. That is something I've really found from using a lot of tofacitinib in the clinic in the last couple of years. The drugs aren't interchangeable. The positioning of each molecule is unclear. It's also unclear about what to do when one has failed. Can you use another? I think which we use will depend on local availability. It will depend on cost. It will depend on real-world experience and other data sets as it emerges. As I've mentioned, the dose is ultimately limited by safety. This is partially overcome by selectivity and may be overcome in future by targeted delivery. They may be future agents for acute severe colitis. This is a very interesting area to watch, but please just watch it for now. I would encourage people not to go around experimenting for this at the moment. Remember, there is appreciable mortality, not just morbidity, if we get the management of acute severe colitis wrong. And I think also these drugs may become a very interesting, flexible plank of future combination strategies. Thanks for watching. I'll look forward to seeing you soon. Subscribe to Atomic IBD. You'll see other video suggestions here. But for me, for now, thank you and goodbye.